Good morning. Good morning. My name is Adrian Dix. I'm the BC Minister of Health. To my left is Dr. Bonnie Henry, our Provincial Health Officer. Just to give you an update, we're honored to be here on the territories of the Lekwungen-speaking people of the Songhees and Esquimalt First Nations to give you an update on what you can expect over the next day. At 3 o'clock today, we'll be releasing a written version of our regular daily report with reports on cases that you regularly see and potentially of other actions that the Provincial Health Officer is taking. Our next briefing after the one this morning will be tomorrow, Saturday, at noon, right here from the Press Theatre in Victoria. Just want to note for members of the media and for members of the public, we had a technical briefing for the media prior to this at 9 o'clock, where we went through a slide deck, this one of 33 slides. This slide deck will be made available on the BC CDC website around the end of this presentation. The slide deck, it took about an hour to go through, so the slide deck and the slides that we're presenting today are slightly shorter than that for brevity. But Dr. Henry and I are prepared to take questions on, of course, all of the information that's presented this morning, and all of it will be available to members of the public. And with that, I wanted to introduce Dr. Bonnie Henry.
Thank you and good morning. So this is something that we've been looking forward to being able to share with you all around some of the work that has been done around modeling and how it has informed not only how we're monitoring the progress of this pandemic in BC, but also how it's informed our planning, and that's really important. And I will start with saying that this is modeling. So it is not a prediction. It's not a prediction of where we might be or how we might go. It's a set of parameters that allow us to make some rational decisions about planning. And as well, there's different types of modeling we're going to talk about this morning, and we'll get started with working on this. So the first type of modeling that I'm going to talk about is around how do we know where we are compared to what other populations have happened around the globe. And the BC CDC has done most of this work, and it is modeled around what's happening in Canada, what's happening around the globe. And I will say that there's a slight chance of optimism, perhaps, that our rate of growth is being impacted by the measures that we've put in the last couple of weeks. But I'll show you, walk you through that. So this shows what we call a case rate comparison. So rates mean numbers per population, and what we're using here is the numbers of cases per million, and we're comparing different jurisdictions. So this one, we pulled everybody back to when they first hit the rate of 2 per million population, and so for BC, that pulls us back to day one. We're a little bit ahead of the rest of Canada, and that's why the line for BC is a little bit farther ahead than the line for Canada. But as you can see, the lines for Spain and for Italy, Norway, Germany, some of the other countries have started to dramatically increase, usually around day 7, day 8. And what we're seeing here in BC and in Canada is that line has stayed relatively low. It is, of course, starting to increase and has been increasing about day 14 until now. And we'll talk a little bit more about that. What also you can see on this model is South Korea, which also started increasing in the first couple of weeks and then flattened out. And that's what we need to, when we talk about flattening the curve or flattening, bending the curve, that's what we want to look at for BC. We don't want it to get that high, but that's what we've been talking about in terms of flattening the curve. We can also see that the United States is also behind in the time frame of since they reached 2 cases per million, at least reported 2 cases per million, and it is now starting to move dramatically increased as well. So that this modeling is based on comparing what's happening in BC to what's happening in other countries and pulling it back so that we're all on starting at the same time frame. And this comparison looks at the cumulative numbers of cases. So these are what we've been presenting every day, the number of people in BC who test positive for COVID-19. And it compares that to the number of cases that test positive in other parts of the world. And in this case, we've been looking at how the outbreak flowed through time in Hubei and in Italy. And again, this starts at when you've had 100 cases in that jurisdiction. The reason that we pull things down to 100 cases or 2 cases per million is because below that, when you have very small numbers, things can change very dramatically with just 1 or 2 numbers difference. It's what we call unstable. So we try and make it as reliable and as stable as possible so that we have an accurate comparison. And of course, that's one of the reasons why we haven't presented these data before now, because we haven't had enough cases to be confident that this is actually meaningful. But right now, we are confident that this gives us a good sense of where we are in our trajectory right now in BC compared to these other jurisdictions. And as you can see, the dark red line is British Columbia, and we are trending up clearly, and we know that because we've had new cases every day, and those have increased in the last couple of weeks. But we are maybe starting to bend a little bit here. I will say that this is based on cumulative cases, and as you know, our testing strategy has changed over the last few weeks, where initially we were very focused on testing people who had come in from other countries so that we could detect when people were coming into the BC and into Canada with this disease. We've now changed our strategy because we know that people who are coming into BC have potentially been exposed to this, and we know where their exposures are. So our testing strategy is focused on our community, on people who are getting infections in BC, and also on our healthcare system. Very specifically, we are looking at making sure we detect any cases in our hospitals, in healthcare workers, and in long-term care, because we know those are where we can get outbreaks, where we can get transmission that can take out healthcare workers and our health facilities. So we've been very focused on making sure we understand what's happening in those facilities. Having said that, we have not stopped the volume of testing that we're doing. What we're doing is focusing it in on the highest risk populations, and we've been doing 3,000 tests a day, more than many other jurisdictions, and actually comparable to what we saw with a testing strategy in other countries like Singapore, like South Korea. And I think that's important. So the second type of modeling that we're using, there's different, lots of different types of models, but this is one that's looking at how is the change in BC happening over time, and it is looking at the percent change or the daily increase, the trajectory of the cases that we're seeing here in BC. We also are doing some what we call dynamic modeling that looks at impacts of measures that have been taken. But that modeling is still at a very early stage because we haven't, thankfully, had a lot of cases yet in BC. And we are still within the time frame of implementation of some of the broad social measures that we've all been impacted by in the last few weeks. So I'm going to walk through this slide in a little bit of detail so you understand what I've been looking at quite intently every day for the last number of weeks. So the red line is what we are actually seeing in British Columbia right now. And as you can see, we started really, this is again rates, so numbers of cases per million in British Columbia. And on the 4th of March is when we started to reach that threshold of 2 cases per million in our province. As you can see, things grumbled along for a little while, and then around 14th, 15th of March is another really important day. So the 13th was when we announced travel restrictions, when we announced some of the major orders that and restrictions on movement, and we started implementing the important physical distancing measures in our community. And that was because we realized that we were seeing transmission in the community that was not related to travel or to known cases. So very early on, we put in some of these now, very restrictive measures that we've been seeing put in place in countries around the world. So I look at the 14th, 15th of March, when schools were closed for March break, when we had these travel restrictions and implementations of our social distancing, starting to get that message out. It is, of course, as we know, taken a couple of days for people to understand, what does that mean for me? What does that mean for me as a business? How do we manage in groups like restaurants and bars? And as you know, we've restricted how they can work. We've restricted certain businesses where you can't maintain those physical distances. All of those implementations started the week of March 15th, 16th. So for me, when I'm looking at this curve, I know that there are people who were exposed to this virus prior to that date who are going to become sick in the 14 days after their exposure. So it is not surprising, and we've been seeing that in the last 10 days. We've started to see people becoming ill. What these important measures that we have put in place that all of us need to pay attention to, these distancing measures, we're going to start to see the impact of those in the coming week to 2 weeks. So the second incubation period from when they started. So when we look at this graph, that's what we're starting to see in the red line. And I'm trying not to overcall it, but I do believe we've seen a flattening, a falling off of that curve. And we can look at the gray line, and as you can see, the gray line continues to go up. And so that is what the modelers think would have happened had we not put in some of the measures that we put in. So there are a couple of things. Our trajectory, so the progress that we're seeing, changed from an increase of about 24% per day down to around 12% per day. So that's a slowing down of the numbers of new cases, which is good. And it's because of a whole variety of things. One is our changing testing strategy, but also, driven by our physical distancing and the important thing that everybody is paying attention to that physical distancing, as well as the restrictions in travel. So that other group of people that were continuing to come into BC, having been exposed to this virus in other countries, that has also stopped, and that's made a difference in our trajectory as well. So that is the part that I'm going to be watching very, very carefully over the next coming weeks to months. And that's the part that we talk about when we're saying, bending or flattening that curve. Finally, I will say, that if we look at this, and these are, again, approximations or models, right now, we're, with our reported cases, we're about 130 cases per million population. If we had continued on the same trajectory that we had been on the 14th of March, we would have expected to have about 215 cases per million. So we think that we've reduced that quite dramatically. What we need, though, is for everybody to continue to pay attention to these measures so that we can continue to prevent the transmission in our communities, continue to separate, to stop those chains of transmission in all of the settings in our communities for the coming weeks. And that's what we'll be watching going forward. And finally, just so you know, the blue line on there, again, Canada as a whole was farther behind in reaching that 2 cases per million rate. And the blue line reflects what's happening across the country. And really, the steep inflection in the last few days has been because of the inclusion of a number of probable cases in Quebec that added to the total quite significantly. So this is the modeling that we've been using, both to follow the trajectory that we have, and now I'm going to turn it over to Minister Dix to look at some of the other models that we have put in place that have helped inform our planning. And again, I just want to say these are not predictions. They're actually using of data to help us plot a course that we can all get around and understand how we might be able to respond to our pandemic as it evolves in BC. Oh, okay. There is one more slide that talks about our expected rates of growth, and I've just talked about this. There is value in our planning for these high responses, and I'll turn it over to Mr. Dixon.
Dr. Henry has control of the clicker today, which is a good thing for everyone. So I want to talk about our acute care capacity and how we are planning for various scenarios to deal with the coming weeks and potentially months in British Columbia. I want to thank the people involved in this planning. It's an extraordinary group. Dr. Henry talked about the team mostly at the BC CDC, which was involved in the modeling. We're also talking about a provincial critical care working group that has come forward to deal with what we need, our projections and what we need. Here in British Columbia, of over 20 medical directors, executive leads, and clinical specialists responsible for ICUs and high acuity units, along with the epidemic modeling team from the BC CDC and an operational capacity modeling team that has assessed our capacity as a province against 4 scenarios: South Korea, Hubei, Northern Italy cases, and Northern Italy hospitalizations. The reason we have done 2 for Northern Italy and made 2 preparations for Northern Italy is to deal with the most severe version, which is focused on hospitalizations in Northern Italy, which has been the subject of some discussion in BC and elsewhere in the previous week. I wanted to also say that this assessment, the full assessment, because this will be a short version of that assessment, is going to be made available in a technical briefing. Was available this morning to a technical briefing. It's fully going to be on the BC CDC website. So all of the information that was available and made available this morning will be available to everyone in the public. The assessment really has 2 areas of focus. The first is focus on our current capacity with respect to critical care spaces capacity and our current capacity with respect to ventilators for critically ill patients. That cohort of patients that will require critical care, and the model assumes that that would be roughly 4.7% of patients. And the second is a focus on current hospital bed capacity for less acute patients requiring hospital care, which is also hospital capacity. That is a larger group of people, between 13 and 14% of patients. And so if you go to the next chart, you'll see models based on a South Korea type epidemic, a Hubei type epidemic, a Northern Italy type epidemic involving overall number of patients, and a Northern Italy type epidemic based on a hospital-based scenario. And you see the different lines as they go forward. The one in red at the bottom is South Korea. I note the star, if you look at it on this chart, that is British Columbia, where we are today, based on the work of our epidemiologists. So if you look at those numbers, you'll see the trajectory in South Korea, then the trajectory in Hubei province, which I remind everyone was a very, very serious epidemic indeed, which is still proceeding but coming down the slope here. The one higher in mauve is in the light mauve, I think you'd call that, or purple, is Northern Italy based on critical care patients. And then the final one is the Northern Italy, which is the hospital-based scenario. You'll note that the last 2, of course, have not finished because they've not fully peaked. And so those are in terms of the planning. And on the side, you're seeing what that would mean for patients in British Columbia based on those various models. The next slide addresses our ventilator capacity. So we've told you we have 1,272 ventilators currently, or we did last week when we reported out on the number of ventilators in BC. But we're using conservative models there. Some of those ventilators are used, for example, for transport, and we're certainly going to need those ventilators. But the focus here is on our current inventory of critical care vents, particularly for adults. Our children's or our pediatric vents will be at BC Children's Hospital, but we are expecting a relatively small number based on all other jurisdictions of children requiring ventilators. So with that, you see that we have in total 457 adult critical care vents. 109 of those are in smaller hospitals or small hospital vents. And so that leaves us a total of 348 vents in the 17 hospitals that will be our COVID-19 centers, at least at the beginning. I note that we, as we said yesterday, we added 15 ventilators yesterday that we have purchased. We've refurbished 38 ventilators that are ready to go, and 19 other ventilators that will be ready to go next week that will be in addition to the 1272, in addition to the 348. So that's 72 more in those categories. And we also have ordered more ventilators, which we're expecting to come next week. So that gives you a sense of the ventilator capacity in British Columbia. Our conclusions, and you've seen this as we've dealt with the various scenarios, are that using the likely scenario of below or at a Hubei epidemic level using ICU and high acuity unit bed capacity along with vent capacity, we are reasonably focused on being able to handle that within the 17 COVID-19 care sites. If we were to move to a Northern Italy trajectory, BC would have to use all sites to meet bed demand and implement increased transportation of patients between sites. And again, the more detailed discussion of that can be found in the longer briefing. I'm going to move on to the second category of patients, the patients who are in acute care but do not require critical care, based on models around the 4 models we're using here. You'll find that the expectation here assumes that 13.8% of all COVID-19 cases will be admitted to hospital. The admissions will commence five days, and the range is 2 to 7 days after case identification. And you see the same projections here, and you can see what happened in Italy in particular, where the system was at 100% capacity at the time when the surge of COVID-19 patients came. And so you see the extraordinary challenge, and you've seen visually through reporting the enormous challenge that presented for the healthcare system in Italy. It's why we canceled elective surgeries based on the advice, based on what we were seeing, based on what we were advised, based on projections like this. About 11 days ago now, cancellation of elective surgery and other decanting or moving of, for example, alternative level of care patients out of acute care hospitals to create space, not just space to address COVID-19, but space to ensure that we're ready for other things and other care that will be required in the healthcare system. Again, you see the 3 levels of chart. You see where BC is now. You see where which is closer to where South Korea was. Then you see the effects in Hubei in green, and the 2 Italian models there that we are preparing for. So we're going to summarize a bunch of the information that we have, and just to say, and you'll see this, who will see the full package, will see how we charted this against the various models, and you'll see as the number of patients would rise and as bed requirements rise. On the left, you'll see our potential capacity, which starts with ICU primary COVID sites, and then we add the high acuity sites, 50% of them, because the other 50% will certainly be required for other care and for other care in the healthcare system. So that adds to 263, and then we add 85% of the cardiac care unit sites, the cardiac surgery ICU sites, and the post-anesthesia recovery rooms in the system to build up our capacity of beds. And then you see as you come down here for South Korea, into the positive, that's how many beds we have more than needed in the various scenarios. And obviously there are more significant challenges when you get a Northern Italy type situation. Again, in the second group, the acute care, acute inpatient care demand, you again see a similar chart which shows us adding beds as required to increase our capacity to deal with COVID-19. And you'll see the big challenges here. And this is why, if you look at this, the most serious model, the one, the Northern Italy type epidemic, the hospital-based one, which we do not foresee, but which we have to prepare for, you see a shortage of beds here and only here. And in that case, It's why we're preparing each of our health authorities, in each health authority, significant new bed capacity and preparing for that. Not because we expect it to happen, but we have an obligation and we are a determination to be prepared for that to happen. So a few conclusions. Using the likely scenario of below or at a Hubei epidemic level, using inpatient medical and surgical beds, capacity looks good, focused on using all sites. This has been enabled in large part by the decision made by health authorities and by the government to defer scheduled surgeries, which has opened up significant surge capacity across hospitals. If BC was to move to a Northern Italy hospitalized trajectory, BC would use all sites and bed capacity off-site from hospitals for less acute and surgical inpatients to open up additional capacity for COVID-19 patients in hospitals with ready access to critical care. You're going to see that start to happen, those preparations start to happen starting next week with Vancouver Coastal Health, and we'll have more information on that. In other words, while we are absolutely determined to have the best results, we are preparing for the worst possible scenarios. We presented a range of scenarios based on evidence from other jurisdictions and a set of grounded, clinically oriented assumptions. As the days of the epidemic pass here in BC, our needs will become more clear. I think it's fair to say, Dr. Henry, that our epidemiologists would always say that next week they'll be better and the week after they'll be better, and we are going to obviously continue to update this as we go forward. Our health authorities are planning for a cascading response, and they're working to find a balance between the needs of potential COVID-19 patients and reducing the risk of unintended consequences on other non-COVID-19 patients needing access to acute and critical care. So as we create new and other options, our intention will be to continue to move other patients out of the hospital if in fact our hospital begins to face challenges in dealing with critical care and overall patient care in the hospitals from COVID-19. So we're putting in place a plan. Health authorities, each of them with their own emergency operations center, are putting in place a plan with their clinical and support staff. They're putting in place a 4 to 6 week staffing schedule based on their planning. This will involve redeployment of key clinical staff to support critical care, redeployment of staff to support non-acute inpatient COVID-19 care, accessing additional staff to support both non-acute surgical and medical care, and that includes re-registrants and trainee healthcare professionals doing the less critical care work, enhancing primary and community care capacity, support and monitor COVID-19 patients who are in self-isolation, and that will be important, and why the innovations in terms of virtual care are so important. Maintaining, and this is critically important, primary and community care needs to meet the health needs of all patients, all non-COVID-19 patients, which of course are continuing to occur, and providing support to clinical care professionals throughout the surge. I want to thank representatives of professional organizations and of unions. We met with them last night for their work and their support and their commitment. They are a critical part of our leadership team, and we are taking steps with them to help address the human resource challenges. And finally, health authorities are also focused on the third aspect, the first being beds and capacity, the second being human resources, the third being personal protective equipment, on implementing measures to best use personal protective equipment based on existing at-hand and warehouse supplies. We're obviously focused every day, every minute of every day, in fact, on securing additional needed PPE in the coming weeks and throughout the months of April and May. And finally, these are, of course, projections based on different scenarios. And Dr. Henry has spoken about this at length. But what's required to bend the curve, we sometimes call, what's required to make the projections better is 100% commitment from people everywhere in British Columbia. 100% commitment. The idea that if you're sick, you have to stay home. 100% commitment to the idea if you're required to self-isolate, 100% commitment to not take unnecessary trips. 100% commitment. 100% commitment to distancing between one another so that we can continue to bend the curve, that we can ensure that the resources that we've made available in the healthcare system and the passion and commitment and brilliance of our healthcare workers, our doctors and our nurses and our healthcare workers and our pharmacists and everyone else in the system can be used to address the challenges we face in the coming weeks. 100% all in. That's how we change the projection to the better, 100% all in. That's how we deal together with COVID-19 in the coming weeks, days and weeks and months. Thank you very much. And I'm going to ask Dr. Henry to return here, as she has a couple of additional announcements that are relevant today and an additional order to describe, and then we'll be open to taking your questions.
Thank you. This is a lot of work summarized in a very small amount of time with a few graphs that don't begin to describe the amount of thinking that has gone into this. And I think the importance as well is engaging across the entire health sector on understanding what we can do and how we can do it together to protect the health system and to protect our communities in doing that. Today, though, there's one other order. I'm issuing the following order. All episodic vending markets, what we know as farmers markets or community markets, must only allow vendors that serve food to be sold at these events. So vendors of all other merchandise at these events are prohibited. And this is recognition of how important it is for us to be able to access locally grown and produced food, and the farmers markets are an important part of that. But we don't want them to be areas where people are going and mingling in large groups because of the risk right now that entails. I will recognize, though, that the Ministry of Agriculture is working with the BC Association of Farmers Markets to make sure that we can have online models for farmers markets that will still allow us to get that fresh fruit and produce that we need here in British Columbia through this crisis. So I think it's an understatement, really, to say, but our global community has changed in ways we could not have imagined even a few weeks ago. And the modeling, the thinking that we've been doing really reflects that. But we are in this together, and we are making a difference in bending that curve. And we need to get us through this together by all of us being committed to continuing to do this, to being kind, to staying connected, even though we are physically distant. And we'll be happy to take your questions now.
Okay, so friendly reminders, please press *1 to enter the queue to ask a question. Limit yourself to one question only, and please take your phones off mute. You will not be audible until we call on you. First question comes from Paisley Woodward at CBC. Go ahead, please.
Oh, hi, Dr. Henry. You said today that, maybe the curve is starting to bend a little bit. I'm just wondering how would you say it that the data does tell us about how well we're doing at that? And with the advice in place now for physical distancing, we're wondering if it should be bent a little bit more, and are you expecting it's going to flatten in the coming weeks?
Yeah, I don't dare talk about expectations. What I want is for it to flatten more. As we talked about, it really is the first 14 days we might not yet see a difference, and that's because we know people have already been exposed. And we know that we're playing catch-up a little bit with the cases that we've seen arise in the last week, where some of them have exposed others, sometimes larger groups of others, and that's the public health work that is ongoing today. When we talk about the testing strategy and focusing on the clusters and outbreaks that we're finding in our community, that is happening around the province right now. And that's going to mean that there are still people who are going to develop this disease over the coming 2 weeks. But if all of us have done our part, and I'm starting to see some glimmers of hope, if we will, that we've flattened out, our trajectory has leveled off a bit. We need to see that continue, and of course, ideally, we want to see it go down. We probably won't be seeing it going down for a while yet, but this trajectory allows us to maintain our health system, allows us to be able to provide all of that important health care to people with COVID-19 as it's needed, but also to everybody else who needs the health system care. So I think it is working, and I want to tell people that what you're doing is making a difference, and we need to keep it up for the next coming weeks.
Next question comes from April Lawrence at Czech News.
Hi, thank you. I'm just hoping you can tell me of the 17 primary COVID sites, which ones have been designated on Vancouver Island. And having said that, in an area with so many remote communities, that will obviously rely a lot on transporting patients from communities to these designated sites. Are there enough, do we know how many ventilators there are for transportation, and do we have enough?
The question of do we have enough is something we will not know until we're at the end of this, but we feel like we have additional and sufficient transportation ventilators. But the whole strategy of how to move people around the province as this progresses in the coming weeks is something that is very much being focused on. On Vancouver Island, the Jubilee and the Nanaimo are the two main COVID hospitals designated. So yes, the strategy is being worked out with BCEHS to make sure that we can effectively and efficiently transport people as needed between those sites. And of course, in other parts of the province, the north and the interior, those are really critical considerations as well. And so there's a lot of planning about looking at how we can do that. Also, as you noted, we have a number of ventilator capacity that is outside of what is in the projections, including the 15 that came this week and a number of others. And so we're looking at how do we effectively pre-position those in parts of the province where they might be needed to make sure that we have things in place if and when this progresses in different parts of the province.
This is to say that the 17 sites will prepare and attach to the presentation the full list so that people from other parts of the province who will be asking the same question can have all that information all at once. And as well as Dr. Henry has said, with the 72 ventilators on hand, ones we have on hand, we're obviously planning in every single health authority to ensure that if gaps exist or if we're under projection in a particular area, we're filling those gaps in the coming week, and that work is being done now by critical care units. The reason we focused on 17 critical care sites, was on the advice of our critical care team that was the best way to organize, but all of our hospitals are integrated into the plan.
Next question is Ashley Legasek, CFJC Kamloops.
Hi, Dr. Henry. I brought this up earlier this week, but what's the estimate for the actual number of COVID-19 cases in BC, and how accurate can today's projections and models be if the demographic of people being tested is relatively exclusive?
Yeah, well, I'll address the second question. The demographic is not exclusive. That's not the right way to characterize it. The focus is on people who are at highest risk of having this and the highest risk of creating issues with our health care system. So we want to be able to absolutely detect outbreaks in hospitals. We know that our long-term cares have been affected, particularly in the Lower Mainland. So focusing on those people who are in that milieu is important to help us understand risk and to be able to determine the people at highest risk in those settings. So we're not excluding people. What we're doing is focusing the testing on where we don't know the source. And again, going back to estimations of numbers, there's models that help us do that. And I presented our expected the numbers that we're seeing right now is about 130 cases per million. That would give us, what we, in the range of 2,000 to 3,000 people probably in the province that were infected at that point in time. But again, these are just models. So our testing strategy has been to test widely, and we know that there's transmission happening in communities that we don't recognize, and that's where we have to focus our testing and our public health response on those as they pop up.
Next question is Binder Sudjan from CTV.
Hi, thank you for all the information. I wanted to know, given all the information that you have, how confident are you that at the peak of this pandemic in British Columbia, that people will have access to the ventilators, to the beds, and to the staff that they will require?
Yeah, and so much of that depends on us all doing our part to keep this from going explosively, like we've seen in other places. But even if we were, and this is what the planning has focused on, even if we were in a situation like what we've seen in Italy right now, we feel that the planning that's being done should allow us to adequately care for everybody who needs it in those scenarios. It does mean that we would be, as things progressed and as we watch the trajectory, and that's where the modeling informs the planning, we would be able to cascade and increase the number of critical care beds that are available, hospital beds that are available, and we have plans for people to be able to, obviously it's critically important that we have the human resources to staff those facilities, but we also have plans for, if we need it, to move people who don't have COVID-19 out of hospital into an alternative care facility, and there's been preparations in each of the health authorities to determine what that might look like. And there's a rationale for why we would move other people out of the hospital, not put people with COVID-19 in another facility. And that is because it is safest for all, both the healthcare workers and the healthcare sector, if we keep people together. So it means that in hospitals right now that are treating people both in ICU and in hospital with COVID-19, they're all in a separate area together. And staff who look after them don't look after other people in the hospital. It's not like we have people sprinkled throughout the hospital, because that is riskier. It means that there's a probability that transmission could happen in the facility. So hospitals have been working very diligently over the last few weeks to hive off areas where we can care effectively for people with COVID-19 and for everybody else who needs hospital care. And then people only work in one area or the other, so that we're not transmitting between people as well. So the important thing that we can do is expand the capacity in hospitals, in all of our hospitals, and move people who don't need as high level care or can be managed in an alternate facility by others in the community. So that's the big question. Are we going to be okay? We have put a lot of thought in this, and I think probably the most important thing is that we've engaged across the health sector. All of the unions have been involved, those people who are working in critical care, who are working in the hospital sector, who are working in BCEHS, infection control, our leadership in the health system have really put their minds to how can we be as prepared as we possibly can. So now we all have to do our part to make sure that we don't get to that point. And that's why it's so important, as I keep saying again and again, it's so important for us all to take these distancing measures seriously, because it is making a difference, and we need it to continue to make a difference for the next coming weeks to months.
Just to say that I think that this reflects the determination of both Dr. Henry, of our Deputy Minister, who people in the media heard from this morning, Stephen Brown, and the whole healthcare system. Our emergency response started, I believe the date was January 28th, so basically 2 months ago. And steps were taken at every stage. And the fact that this has come later to us than it has to Europe, and obviously it did in Hubei province in China, has given us some advantages in terms of preparation. So all of the health authorities have been working together for 2 months, and the work you see here reflects that. And all of the work done to identify the initial, mostly travel-related cases and breaking up links of transmission, all of that was important. And then all of the work that Dr. Henry and her team in public health across the province have been taking, and all of you have been taking, all have a positive effect. So what we're doing here and what we're presenting here is not what we expect to happen. There will be a BC epidemic here, a BC COVID-19 situation that will develop. But what we wanted to do is prepare should that situation be as bad as places such as Hubei and as Italy. And we've been preparing for months, and the work here reflects that. So if it gets serious, we are preparing the most serious possible scenario. We are preparing for that scenario regardless of whether it's the most likely scenario or not. And I think that's what people would expect us to do, and that's what the months of planning led by Dr. Henry and Mr. Brown and so many others, dozens, hundreds of people across the province will bring about. And again, as Dr. Henry has said, I just want to express our appreciation both in long-term care and acute care and public health across British Columbia. The work of workers in every area, of doctors, of nurses, of healthcare workers, and their representatives who have been extraordinary and are a key part of our team. We wish to again thank them very much.
Next question comes from Brishti Basu from Victoria Buzz. Go ahead.
Hi, Dr. Henry, Minister Dix. I'm just going to circle back to the statement that you made about Canada's overall cases rate going up because Quebec reporting probable cases. I was just wondering if BC were to start reporting probable cases as well, how far would you expect that number to rise in BC?
Yeah, so we have been reporting all of our cases. So it was similar to what we ran into a couple of weeks ago when we were expanding the testing to different labs around the province. For a period of time, those tests had to be validated at the BC CDC, and we had a little bit of a catch-up. We didn't have as big numbers as they had in Quebec to catch up, but you saw that reflected about 10 days ago when we had a couple of days of very high numbers, and that was because all of the tests that were being done at St. Paul's and VGH were validated at BC CDC. So we don't have that issue anymore. All the labs are now validated, so every positive test that they have is reflected in our numbers right now.
Next question is Mark Jones, Peace FM.
Thank you, Dr. Henry and Minister Dix, for providing these updates. So the question I have is about the COVID-19 testing and the availability there's a perception in the Northern Health Region by some citizens that it's not easily available. I do know there is the assessment tool, and it's basically like a decision tree. If you meet these criteria, just isolate. I guess the question is, in a succinct way, is would it be up to the 811 medical people or 911 to determine, or the doctors in an emergency ward, if that's where they're directed to go, whether a patient gets the test? There's a perception that some people feel they are not getting access to a test, especially in the Northern Health Region.
Yeah, and it has been a challenge in the Northern Health Region. Those tests are available, and they are available if somebody calls 811 and goes to an emergency department. The protocols that we have, they're also very much being used on a daily basis when public health is investigating clusters and transmission in the north. So there has been widespread testing in many communities in the north based on the public health investigations that we've been doing and people who have been contacts. So early on, and the North was no different, when we were focusing on people who were returning travelers, there was challenges with getting returning travelers in the North access to tests. That has changed now, and our advice for all returning travelers is that this is a risk and you must self-isolate for 14 days. And if you have mild illness, we don't need to test you, so we don't want you to leave your home and go to a testing center or a hospital because we know there's risks to that. We know if you have mild disease that can be managed at home, that's fine. You won't be counted in the test positive numbers, but we also are aware that the important thing is you're not going to be passing it on to anyone else. So that's the strategy we have. We've been, of course, working to try and increase turnaround times in the north, which can be a challenge. And I know with Life Labs coming on board and some of the transportation networks coming on board, that's being addressed as well. I think the other really important thing in the north is making sure we have processes in place, and I know Northern Health and our public health people have been working very hard on this to rapidly identify if there's clusters in communities across the north, and that's been the focus of the testing as well.
Eugenia Smith, CBC.
Hello, you can hear me?
Yes.
Yep. So given the US is now the worst case scenario, we've learned in the last 24 hours that the country has the most cases of coronavirus in the world now. Looking at the trajectory modelling that we've looked at today and the fact that it's based on Hubei province and northern Italy, do we need to rework this modelling following the ministry's so-called abundance of caution, or are these sort of trajectories still appropriate for BC?
Yeah, and so obviously we used what we had available, and as you can see, Italy has now probably leveled off. It's not on the downswing yet, and we have been putting in the U.S. as well. I don't believe that we need to redo the modeling. The scenarios that we're seeing in the U.S. are very much like Canada, where different states have different issues going on at the same time. So modeling all of the USA is not likely going to give us much difference. I think the scenarios that we have, or I believe the scenarios that we have used, are ones that will keep us in good stead. Our modelers are, of course, factoring in all of those new numbers to see if there's anything else that we need to prepare for. But as Minister Dix said and I've said, we are going to have our own epidemic. These are just a basis for change. These are things that help us say, okay, what do we need to have in place? And the exact numbers are really, in my mind, not that important. It's much more about how are we managing? Are we within our capacity? Have we done everything to ensure we know what our capacity is and where it is, and put in all of those pieces that allow us to cascade up if we need to. So we will be factoring in, of course, some of the issues from the U.S., but I don't believe it will change any of the work that we've done to date.
Next question is from Aaron Linkletter, Dawson Creek Mirror.
Yeah, hi there. I'm just wondering if the measures are enough, or if we're going to see further restrictions, maybe restricting travel between provinces, something of that nature.
And that has been talked about at the federal level with some of my colleagues, and in particular, I know in the North and the Northwest Territories, the Yukon and Nunavut are very concerned about small communities being quite spread out. And I know already there are some restrictions in terms of people who have traveled being asked to self-isolate or being required to self-isolate once they've moved into the area. The same with my home province of Prince Edward Island, who would want me to be quarantined if I came home right now. Those are measures that particularly are important for smaller communities. The message I have for everybody in BC right now is that this distancing is what is going to help us all. And that means don't take unnecessary travel. There are reasons why people need to travel. They need to travel to support family. They need to travel because they're part of the essential workforce that moves goods and people across our country. And we need to support them in being able to do that. But if there's non-essential travel, now's the time to stay at home, to cocoon, to look after your own family, to look after your own community. And doing that means having the physical distance here and staying connected with our families across the country, with our friends and loved ones through virtual means.
Next up is Richard Zisman from Global News. Go ahead.
Henry, you were asked a similar question, but just specifically, when people see the information today and they see that the numbers are leveling off a bit, that we're doing well, for those who are struggling with following all the guidelines, do you think that this could be seen as motivation to back off some of those guidelines a bit, saying, oh, look, we're doing well, I don't really need to follow all this along? And then also similar to something else you spoke about, we're hearing stories about personal protection equipment, especially in more remote rural areas around nurses being asked to use ski masks and other equipment like that. Is that appropriate to be in hospitals with sort of the equipment that people can find because there's not enough PPEs?
So to the first question, I hope this is motivation for people to double down on what we're doing, that it may be working. I can't say it is working yet. It may be working, and it is incredibly important. And the modelers have shown us that if we do this right, it is what is going to save us. It's going to save our healthcare system. It's going to save our communities by taking those physical distance measures that we've put in place now. And all of us need to continue to do that. We've looked at other places where they've eased off on the measures, and we've started to see increases again. So we right now are in the middle of our pandemic. And our pandemic is going to be different from everybody else's, but this is our critical time. The next 2 weeks in particular are our critical time, and we will know if these measures are working. So I'm hoping this will encourage and inspire people to realize that what they are doing is making a difference, and we need to continue it and to support each other to continue it going forward for the next few weeks. And then we can reassess, and we'll see where we're going. But what I don't want to see, what I lie awake at night worrying about, is that line is going to start to dramatically increase again. And that's what's going to happen if we let things off too quickly. In terms of PPE, that is something that we are obviously working on. We have had a provincial logistics group that has been looking at all the medical equipment that we might need, ventilators being one of the things. But personal protective equipment for healthcare workers is something that is near and dear to all of us, and we have been working relentlessly on that. We have taken a number of different steps, including innovative ways of reprocessing and cleaning, getting it from wherever we can. We do have supplies. I spoke earlier this week about my concern that we were using up supplies far too rapidly in some cases. We've now leveled that off. But it does mean that some of us will need to do things differently than what we're used to. And I've talked about cohorting, or putting all of the people with COVID-19 in one ward and making sure that the healthcare workers work only with people with COVID-19 for that period of time. So that allows us to do things differently, like only wearing a respirator or a mask for the duration of our shift, unless it gets soiled or dirty, making sure we have the appropriate complete personal protective equipment we need, but not having to change it and take it on and put it off between patients, which is something we do all the time, because we don't want to contaminate, take something from one patient and pass it on to another. So for now, if we put all of the patients who have, people who have the same disease together, we can care for them safely without having to put things on and take things off all the time. And that's important not only for caring for the COVID-19 patients, but for me as a healthcare worker, my chances of contaminating myself is every time I put on or take off my mask or my respirator, my eye protection, my gloves. So we can minimize those transitions that put risk on healthcare workers. It also means that people in the community, our paramedics, our pre-hospital care people, will be doing things a little bit differently too, so that we can conserve our masks, our respirators, our eye protection, and make sure that we have enough going forward for the next few months. So there is changes, and sometimes that's a challenge for us to take on, that there's a reason for those changes, and we need to do better and make sure that we're communicating those reasons and the importance of keeping people safe.
On the second point, that's a central focus of all of government right now, is to obviously get more PPE, and in the meantime work efficiently to make the changes we have so that we use the PPE that we have better, and that means keeping healthcare workers safe, and that is our top priority. It's necessary for all of us, and it's necessary, absolutely necessary, for us to provide the care that needs to be provided in the healthcare system. It's a top priority. On the issue of should anyone see this as a time to give less? No, we all have to give more. One of the most moving things we've seen, and I've got countless emails from the United States about this, about what happens, I think, at 7 o'clock at night when people make noise in community in support of healthcare workers. Well, we got to do that at 7 o'clock, and we got to keep doing it. It's an extraordinary act of citizenship. But that has to be extended 24/7. If we're going to support healthcare workers, that means following the orders of Dr. Henry 100%. That's how you bend the projections, bend the curve, is to do that. And that's how we express our solidarity with the extraordinary people in our healthcare system. We have to keep doing it all the time, 100%, every day. That's what's at stake here. If we look around the world and we see other circumstances, This is how we make our circumstances better. And so it is the responsibility of the government, and in lots of ways that we've described today, of the healthcare system, of our medical leadership, of our union sector, of everyone else to do what they need to do. And they are all in, but we need everybody to be 100% all in. And more so than ever, if anyone takes anything from this, that they need to do less, that is not the right conclusion. We all have to do 100%, and we have to do it now.
Next question comes from Nick Johansson, Castanet.
You had said earlier that we are at day 21 when it comes to the day 29 peak of hospitalizations mentioned in the modeling. How confident are you that we will see peak hospitalizations in 8 days?
Yeah, no, that's again, it's a model. So we're somewhere around there based on the modeling, the estimations. I don't know when we're going to see our peak. And the challenge of the work that I do, and I presented the epidemiologic curve, is that we don't know when we're at the peak until we're looking back at it. So there is nothing that would tell me that we can back off in any way right now. Our peak may be, hopefully, long and flat, so that we're not getting those spikes and dramatic decreases. If we're really lucky, our peak will be flat and flatter. But, we don't know that. We can't predict that right now.
Next is Justine Hunter, Globe and Mail.
Thank you. Now, I'm not second-guessing the actions taken in the last 2 months, but I'm wondering how we got to this place where on March 5th it looks like you started to track down more ventilators. So after all the lessons from H1N1, the swine flu, SARS, can both of you each just describe our state of readiness that we started from?
So I can talk to it from a public health perspective, because this is something I spent a lot of time on in the last, 30 years of my career. You know what? I have what I call the J-shaped curve of neglect. Something bad happens, and we realize that the work that we do in public health and the things that we have in our healthcare system to help protect people and look after people, we pay attention to it. And then as things go by and it's not so bad anymore, we get complacent, and the resources that go into things like prevention, things like public health work go down. And then, unfortunately, we often see things rise again. We've seen that with tuberculosis. We've seen that after SARS, where there was a lot of effort put into recognition that we have that we needed to put work into infection prevention and control in hospitals, into public health, into those safety nets in our healthcare system. But we also know in this country, healthcare is an expensive proposition. It takes a lot of our budgets. It takes, and it's something that is near and dear and important to all of us. And it's easy when we're faced with fiscal constraints to whittle away at prevention. And we've seen that happen in many, many cases. So much of what we're dealing with now, I think H1N1 is a good case in point, where the thoughts after it was, oh, well, that wasn't so bad, so maybe we're okay. And for those of us who were in public health at the time, it was like, it was bad, and it could have been a whole lot worse. And some of those mechanisms that we've been that we need to have in public health, in prevention, in even things as important as what we call the social determinants of health, poverty reduction. Those are things that make a difference in our ability to be resilient to this type of crises. Having said that, I don't think anybody in the world really felt that we would ever get to the type of pandemic that we're experiencing right now. And I know I have talked for many years in the WHO and these other groups that I work with about some of the measures that we have implemented in the last 2 weeks. And I've said this before, I never ever thought that I would have to do those types of things. But right now, this is what we need to do, and we've seen that across the world. We need to work with what we've got and try and make it better and try and get through this, and then we can reassess, where it is we need to make changes for the future.
Well, I'd say first of all that the work that's been done since we put our emergency response together at the end of January has been extraordinary and farsighted. And obviously we've been preparing to have new ventilators or renewed ventilators. And with the 15 and the 57 that are refurbished and going back into action now, having been in most cases upgraded, we've added 72 as of now. We're not going to count, as I think I said before, Justine, the ventilators that are coming, except they come from the same source that we received the 15 from, which gives us some optimism that they're coming. I think it's fair to say that you can always be more prepared, and that the level of this epidemic, this pandemic, has been a surprise to most public health people in the world. The extent of it, the fact that we're taking these measures, as Dr. Henry said, is extraordinary. I think some of the steps we've taken are important steps. If you look at the long-term care sector and the fact that workers often work at different homes, we did bring in Bill 47 about a year ago, but I think the experience of the last few weeks and of the next few weeks tells us that we're going to have to do more working with that sector to do better for workers and to ensure to the maximum extent possible that workers are working at one care home in future. And I've not and I won't be taking any effort to ascribe blame to those sorts of things. I don't think there's any point to do that right now. I think an important change we made a year ago was to bring in Metro Vancouver home care and home support services, which are critical at this time as well, and we haven't spoken as much about, under the orbit direct responsibility of the health authorities and the direct management of the health authorities. I think that's a positive change in helping to address these questions. I think urgent and primary care centers, which you've talked about a lot, for example, in their expansion, I don't think we imagined the use to which some of them would have been put in the last few weeks. The people who've worked there have been extraordinary, but those were intended to reduce the number of people and to serve the people who are without a primary care doctor. But they've proven to be very useful, I think, in community, and we've all seen this, and people who have seen them in action understand this. So there's lots to do, and I think there will be profound lessons to learn from this after the fact, and I'll be the first learning them and the first to take responsibility. But right now, I'm very proud of the leadership that people in healthcare have shown, the preparations they've made. We've demonstrated in detail here what the circumstances are. You are getting the same information today that we have in making our planning decisions so that everyone can see them. There are challenges. This is an unprecedented health emergency in British Columbia in my lifetime. And I think under the circumstances, particularly those who work in healthcare, have operated as we would expect them to do, with the highest ethics, with courage, with brilliance, with generosity. And I am very grateful to everybody who works in the healthcare system, from those who clean facilities, to those who work as care aides, to health sciences professionals, to nurses, to pharmacists, to midwives, to doctors, to administrators, to everybody. They all deserve our appreciation and thanks. And finally, our 100% commitment to following Dr. Henry's orders and advice. Because if we do that, we're being true to them in this important moment for our province.
Okay, we have time for just a couple more questions. Next is Keith Baldry. Go ahead.
Hi, Dr. Henry. I'm not asking to make a prediction. I know you don't like to do that. But based on what we're seeing over the last few days in terms of numbers, where we stand in those charts versus other jurisdictions, and what you know what's going on behind the scenes in hospitals in terms of planning and all that, are you feeling more encouraged today than you were, say, this time last week, that we're going to achieve the goals you set out for everyone? And secondly, with ventilators, I think there's a medical position called a ventilator therapist or something, whether or not we have enough of those people on staff to actually handle the ventilators.
So I'll address the second one. Respiratory therapists are really a key professional in our healthcare system, and they are part of our human resource planning. They are critical in helping support the critical care world and ventilated patients in particular. So yes, there is a plan for respiratory therapists as well. In terms of, I will be optimistic when we have a vaccine and everybody's protected against this virus. Until then, I'm going to continue to focus all of our attention on making sure we're doing everything we can to try and minimize the impact on our families and our communities here in BC.
Okay, and last question comes from Marie Brook, West Shore Voice. Go ahead, Marie.
Hi, yes, thanks for all this information to the public and the media. You're aiming to build your capacity for off-site non-acute care locations in the communities if the hospitals become full. So have you heard back from all the municipalities as to what spaces are available, and is there a deadline if they haven't reported back yet?
I'll let Minister Dix take that one.
Yes, all the health authorities have been working to identify spaces. We don't need many, many spaces because organization in this area is key and location is key. But you're going to start seeing first in Vancouver Coastal and then probably in Fraser Health some movement on this next week, and we'll be reporting on the wheres next week. But I would say this with respect in general to municipalities across BC, that they have been as a rule, enormously supportive and cooperative, and we want to express our appreciation to them as well. So you'll be seeing more about specific locations as we go forward and where we're planning. And what that reflects is that we are absolutely determined to prepare for the worst, even as that we work and everyone works their guts out to ensure that the best scenarios emerge. And again, people talk about planning and results and scenarios and what we're expecting and whether we're on a given day pessimistic or optimistic. This is an unprecedented health emergency, and the request to everyone is the same today. They have a little bit more information about acute care and about the way we see the pandemic today. We see the epidemic in BC today, but we need everyone to be all in now, 100% all in now, every day. That's how we are true to our families, the ones we love, to healthcare workers and everyone else. Thank you very much. Thank you for your questions. And we'll see you tomorrow at noon. You get a statement later today at 3 o'clock on cases for today.